Welcome, everyone. Thank you for joining today's webinar, Cancer, Obesity and Place. My name is Ikra Haji. I'm part of CADCA's Geographic Health Equity Alliance. The Geographic Health Equity Alliance, or GEA for short, we are a CDC-funded national network dedicated to reducing geographic health disparities related to tobacco and cancer. So GEA, in partnership with CounterTools, is very excited to present today's webinar, which will discuss the connection between where we live, work, and play, and the impact it has on obesity, why this matters to cancer control programs, and what policy options could help address this issue. Next slide, please. Thank you. Before I introduce our presenter, I'd like to go over some housekeeping notes. So all participants are muted by default, and this webinar will be recorded. For general comments, please use the chat box. And for any specific questions to the presenter, please use the Q&A box. That will help us keep track and organize all of our questions. We will have time for the Q&A portion at the end of the presentation as time allows. Also, following this webinar, you'll receive a post-webinar email with a link to the recording, the slides, and any additional resources we'd like to share. There will be a link to a brief evaluation survey, and we kindly ask if you could fill that out. Letters of attendance are given only upon completion of that survey. Next slide, please. I'd like to now introduce our presenter, Elizabeth Gurnt. Elizabeth is a project director at CounterTools. She supports partners across the country as they enact policy systems and environmental interventions to help build healthier communities. CounterTools is a 501c3 nonprofit organization that provides training, technical assistance, and software tools to advance place-based public health and health equity initiatives. CounterTools also manages countertobacco.org, a CDC-funded resource focused on tobacco point-of-sale history, impact, and policy solutions. I'll now hand it over to Elizabeth.
Thanks, Ikra. We are super excited to be able to share a little bit with you all today about cancer, obesity, and place, and how all three of those concepts connect. So let's jump right in. I will start with a little bit of an introduction to CounterTools. Again, like Ikra said, we're a nonprofit organization. We started in 2012, and we were founded and based out of North Carolina, or that's where I'm presenting to you from today. I guess we can say that we're based out of North Carolina, although we are now fully remote and we have employees working from states across the country. Our vision is a nation where healthy living is equitable across communities and every person has access to healthful choices. CounterTools knows that place has a profound impact on the health of individuals, the spaces where we live, work, play, and learn, our homes, our schools, our neighborhoods, our nearby stores, all of that determines our access to healthy living. So this slide just briefly touches on some of the things we do, working with our partners to advance place-based public health and health equity. And here's a snapshot of all of our current and past partners. Our clients and partners are government agencies, nonprofits, universities, educational organizations in more than 20 states, from out west in California to as far east as Massachusetts. And you'll also see on the slide the logos of some of the national organizations and universities, partners that we have. We are a dedicated team of public health nerds, policy wonks, data enthusiasts, visionaries, and storytellers on a mission to leverage our expertise for productivity and positive social change. This image was taken before the pandemic, and we are excited for the chance to update that photo, and we're able to come together in person again, hopefully soon. This photo was taken before I was even a part of the CounterTools team, so I'm looking forward to being able to spend more time with my team in person as well. I also want to point out our equity, diversity, and inclusion statement. At CounterTools, we recognize that not every individual or community has equal access to healthy spaces and opportunities. We know that structural elements, so both governmental and organizational policies and practices, both historical and present, all of that is continuing to disadvantage certain racial groups through institutional racism, and industry targeting is impacting exposure, availability, and access to both healthy and harmful products. For example, we know that historical and ongoing policies like redlining have created neighborhood segregation, which has in turn allowed the industries like the food and beverage industry, which we'll talk about today, to easily target already underserved communities and neighborhoods with marketing for unhealthy products. We'll define health equity to mean that everyone has a fair and just opportunity to be as healthy as they can be, which means reducing and removing structural barriers and obstacles that apply to and extend beyond the retail environment, which is an environment that we talk about in a lot of our work. We also work with our partners and clients to reflect the communities we collectively serve. So this is our commitment to do that, to address health disparities and strive towards a more equitable world. For our full stance on equity, diversity, and inclusion, that's available on our website. But we want to make sure that we start every training and presentation by pointing out that this is important to us. All right, so now to jump right in. Most of you are probably familiar with the fact that poor dietary intake and obesity are risk factors for cancer, in particular for the 13 cancers that are listed on the screen. According to the American Cancer Society, aside from avoiding tobacco use, maintaining a healthy body weight, being physically active, consuming a healthful diet, and avoiding or limiting alcohol intake are the most effective strategies for reducing the risk of cancer. An estimated 18% of cancer cases and 16% of cancer deaths are attributable to the combined effects of excess body weight, alcohol consumption, physical inactivity, and an unhealthy diet. In fact, we see a national modeling study that estimated over 80,000 new cancer cases were attributable to a suboptimal diet in 2015. And we also see quite a bit of research indicating that obesity worsens cancer survivorship, including quality of life, cancer recurrence, cancer progression, and prognosis. So the American Cancer Society definitely recognizes this link and provides guidelines for diet and physical activity for cancer prevention. So along with providing recommendations on things like the duration of physical activity and the makeup of healthy eating patterns, the guidelines also include recommendations for community action because the American Cancer Society sees the strong influence of environment on an individual diet and activity choices, which is what we'll be talking more about today. The guidelines encourage public, private, and community organizations to work collaboratively at the national, state, and local levels to develop, advocate for, and implement policy and environmental changes that increase access to affordable, nutritious foods and provide safe, enjoyable, and accessible opportunities for physical activity, and also limit alcohol for all individuals. I am not going to claim to be a cancer expert today, so I'm not going to attempt to explain all the mechanisms in which obesity is impacting the physiological response, impacting the body in terms of cancer progression. But what I'll be focusing on today is the fact that the places we live, work, and play do influence our health, specifically in terms of what we eat, how active we are, and how active we are. With the link we're highlighting on this slide, I think it's pretty evident that this information should be important to cancer control programs. And there's a huge range of programs and policy options that have been designed to address the impact of where we live on obesity. So I'll be providing an overview of some of those options today. Again, you're probably familiar with the fact that we see disparities in cancer prevalence. We also see similar disparities in obesity rates. So we'll look at some of those to start. As you'll see in the chart on the screen, according to NHANES data from 2017 and 2018, Blacks had the highest rate of obesity, close to 50%. And that was followed closely behind by Latinx and then white, falling closer to 40%. Unsurprisingly, this is aligning pretty closely to the racial and ethnic disparities we see in terms of the cancer burden, which I'll mention is largely reflective of longstanding inequities in socioeconomic status and access to high quality healthcare. And we can also attribute this in part to the historical and persistent racism in the United States. This is also evident in a 2019 study finding that racial inequality in income, unemployment, and home ownership, all of these things are things we consider to be indicators of structural racism. All of that was associated with obesity in this study. You'll also see demographic trends in obesity in terms of geography. The map on the slide displays the prevalence of self-reported obesity among US adults by state and territory. Many of the states with the highest percentages fall in the South. States like Mississippi, Alabama, South Carolina, and Louisiana, which those regions are often high on our list in terms of other chronic diseases like obesity and heart disease as well. According to 2016 BRFSS data, adult obesity rates were 19% higher in rural regions than they were in metro areas, and more than a third of adults in rural areas had self-reported obesity compared to less than 30%, about 28% of metro adults. Unsurprisingly, these rural areas are also having higher levels of obesity-associated chronic disease, so those things like diabetes and heart disease. Likewise, a CDC analysis found that adults who lived in the most urban areas of the country, as determined by large metropolitan statistical areas, had the lowest obesity rates between 2013 and 2016. Another trend we can look at is income and education. In general, rates of obesity are tending to rise as income decreases. So this is generally the case, but there's one exception to the trend. The very poor who live below the poverty line, below the federal poverty line, had lower obesity rates than those with incomes just above the federal poverty line. But in both cases, both those income groups, those below the federal poverty line and those at 100 to 199% of the federal poverty line, both had higher obesity levels than those with incomes at or above 400% of the federal poverty line. We also see that differences in obesity rates between adults with less than a high school education and college grads is significant. According to 2017 data, about 36% of adults with less than a high school education had obesity, compared to only about 23% of college graduates. So again, that's a difference in more than 50%. So if anybody's interested in examining more about how obesity rates overlap with cancer prevalence, here are two key data sources to mention, and I've already referenced them a couple times so far as evidence for the trends we see in obesity rates. The first one I'll mention is the National Health and Nutrition Examination Survey in Haines. It's the source for national obesity data. This survey is looking at adults, considering adults to be individuals over the age of 20. And some of the advantages of this survey is that it's nationally representative sample of Americans, and it combines interviews with physical examinations to ensure data accuracy. One of the downsides of the survey is that there's often a time delay from collection to reporting and a smaller sample size that cannot be used for state and local data and does not always disaggregate data for racial and ethnic groups by age for each survey cycle. The other data source is the Behavioral Risk Factor Surveillance System. This is a source for state level obesity data. It defines adults as individuals above 18. Some of the advantages here are that it's the largest ongoing telephone health survey in the world. And each state survey is representative of the population of that state. And then also the survey is conducted annually. So new obesity data are available each year. One major downside to mention with this survey is that it's using self-reported weight and height statistics, which we know are often underestimates of obesity rates due to people's tendency to misreport their weight and height. Excuse me. So now we'll talk about some of the things that are driving these disparities. Before we get into that and talk about some of the research, I'd like to start with a really quick activity. I'd really love for folks to use the chat to let me know what you ate for breakfast this morning and why. So I'll give folks a minute or two to enter that if you're sitting at your computer. All right, so some of the examples I'm seeing are nothing, no time, protein bar, trying to lose weight, baked oatmeal because you can cook a lot of it and eat it over the course of the week, a Fiber One bar because I was short on time, a granola bar that's easy and quick, another breakfast bar because you're running late, eggs, I love them for both the taste and nutrition, egg McMuffin for convenience, pita bread with peanut butter and bananas because that's what I had, Cliff Bar, short on time in the mornings, leftovers from last night, my usual breakfast, it's what I always eat, trying to increase my health. So we're getting all sorts of different answers. And we see keeps me full, filling, yummy, tastes good. Something fast. Great, that's okay. So we are seeing a wide variety of answers for why. And I've done this activity a lot of times in a lot of presentations. Sometimes I've done it in rooms full of registered dietitians. And I don't get very many answers saying because it aligns perfectly with the dietary guidelines. Eating is something that we all do every single day, but I have a feeling that most of us aren't really thinking about the reason behind why we're making the food choices that we do. I really like this activity as a reminder that there are so many different factors beyond education and beyond our personal preference, things like you all noted in your responses, things like time, convenience, all of that's influencing the food choices we make every day. And many of those factors are at least in part related to the places where we live, work, and play. So I think this slide hopefully captures some of the examples that I heard in your responses, things like personal preference, it's what I like to eat, availability, it's what I had, convenience, it was quick, stress, maybe I had a busy morning, or I think I saw somebody that wrote that they have a small child, and so it was fast and easy. So there's all these different things that are influencing our food choice, but often in many aspects of public health, and especially in my experience with obesity prevention, we see a really heavy focus on addressing this knowledge piece, thinking if we just teach people what's healthy and how to prepare it, then that's what they'll eat, right? Unfortunately, this is just one piece of the puzzle, and until we're able to address these other environmental factors, it's going to be pretty hard to move the needle in terms of obesity rates. The good news is this idea of the influence of our environment on our health behaviors is continuing to gain traction. I think we see this reflected by the fact I mentioned earlier that the American Cancer Society, their nutrition and physical activity guidelines recommend community action to develop, advocate for, and implement policy and environmental changes to increase that access to affordable, nutritious food, in addition to their recommendations for individuals to follow a healthy eating pattern. So today I'm going to talk about the food and the built environment and how these influence our health. In case these terms are new, I'll start off with a quick definition. The food environment is the physical presence of food that affects a person's diet. So for example, this could be the food served for school lunch, or even just whether or not there's cake in your office break room. There's also, the food environment also includes a person's proximity to food store locations and the distribution of food stores to any physical entity by which food may be obtained. So just thinking about the types of food that's available in the stores that are near you. The built environment includes all of the physical pieces of where we live and work. Things like our homes, the buildings, our streets, open spaces, infrastructure. The built environment influences a person's level of physical activity. For example, people with having inaccessible or non-existent sidewalks or no bicycle or walking paths is going to make it a little bit harder to get the recommended amount of physical activity. So there's several aspects of both the food and built environment that drive some of the disparities we already talked about in terms of obesity rates. So I'll talk more about those drivers today. But just to take it back a step further before we start, I want to make sure to acknowledge here again the fact that historical and persistent racism is playing a big role in these pieces as well. So we'll start by looking at targeted marketing. This is something we see borrowed heavily from the playbook of big tobacco, with lots of examples of targeted marketing of unhealthy food to racial and ethnic minorities. I'll make a note to say that targeted marketing in itself isn't the problem in this case. I think it's generally best practice to make sure you're targeting marketing to your audience appropriately. But the problem I want to point out here is that when we're seeing brands disproportionately targeting their nutritionally poor products to certain consumers, in this case, Black and Hispanic neighborhoods. In 2017, restaurant, food, and beverage companies spent more than $1 billion to advertise on Spanish language targeted and Black targeted television, with more than 80% of that promoting fast food, sugar sweetened beverages, candy, and unhealthy snack brands. Again, the specific concern here is the fact that advertisers market unhealthy food even more heavily to Black and Latino youth than to their white counterparts. A 2019 report by the Rudd Center for Food Policy and Obesity found that even when accounting for differences in TV viewing time, Black children saw 40% more candy ads than white children. And on the other hand, brands in the healthier category, things like juice, fruit, water, and nuts, were less likely to advertise on Black targeted TV and did not advertise at all on Spanish language stations. Public health experts raise the concern that Hispanic and Black youth receive a double dose of unhealthy food marketing compared to white non-Hispanic youth, and that this exposure is likely contributing to or exacerbating health disparities affecting communities of color. So some of the reasons why these youth are disproportionately exposed to food-related marketing include the fact that Black and Hispanic youth are more likely to live in communities where unhealthy food marketing is more prevalent. We'll talk more about that in a second. They may be exposed to more of the media where food-related products are advertised, and then food and beverage companies are targeting their marketing specifically for unhealthy products to Hispanic and Black consumers, including young people. So thinking specifically about the influence on youth, we know that extensive fast food advertising is a major contributor to consumption for children and teens. Frequent and widespread exposure to food marketing increases young people's preferences, their purchase requests, their attitudes and consumptions of primarily these nutrient poor and energy dense products that are promoted. Fast food is the most frequently advertised food and beverage category to children and teens. It represents 40% of all youth-directed food marketing expenditures and more than a quarter of food and drink TV ads viewed. So next we can think about some of the disparities in outdoor advertising. In 2019, according to research by the Rudd Center, the top fast food advertisers, we can probably guess who some of those top spenders were. Places like McDonald's, Starbucks, Chick-fil-A, Taco Bell were spending over $5 billion in advertising. And TV was making up the biggest percentage of this advertising spending, but there was still over $185 million spent by the companies on outdoor advertising. Consistent with their high overall advertising budget, McDonald's was spending close to $71 million on outdoor ads. And unsurprisingly, the top spenders are also the ones that are seeing the biggest revenues, which is again pointing to this power that advertising has. So we know the fast food industry, just as one example of generally nutrient poor food options, is spending a lot of money on advertising. But what's particularly concerning here is that we see outdoor ads for unhealthy products of all types, including things like cigarettes and alcohol, are more likely to be in areas with a higher proportion of minorities and low-income individuals. Specifically for outdoor food ads, Latino and Asian neighborhoods had as much as 6 times the outdoor food advertising, and then low-income African-American neighborhoods had up to 32 times the number of outdoor food ads compared to high-income white neighborhoods. Again, we know that this advertising must be working or the industry wouldn't be spending quite so much money on it. One recent paper reported that for every 10% increase in the number of outdoor advertisements for food or beverages, there was a 1.05 greater odds for an individual in that neighborhood being overweight or obese after controlling for income, education, and race. So just proving that outdoor advertisements are playing a big role in our purchasing behavior. Next, we can look at availability, thinking in terms of both high availability of unhealthy products and limited availability of healthy options. Many of you have probably heard this concept represented using the term food desert, or sometimes you hear food swamps. These terms have gotten a lot of criticism from researchers for not being the most accurate measures of food access. And I'll also mention that many food justice leaders are urging us to reconsider these terms, with activist Karen Washington coining the term food apartheid as a way to take into account the systemic racism permeating America's food system. Some issues that she sees with the term food desert, just to point out, is that the word desert makes it seem like these communities are lacking entirely when there is plenty of life and resilience within these communities. It's also a problem in terms of making it seem as though these communities are naturally occurring, kind of absolving responsibility. And again, just pointing out that the lack of affordable and fresh food, making it sound like a geographic problem rather than one that comes from these years of structural racism. I know we're talking today about the influence of geography on obesity, but I think it's important to acknowledge the impact of policies like redlining and how that's been able to impact low access to healthy food in communities of color. So by low access, I can point out that first we see a lack of supermarkets. A 2009 study by the US Department of Agriculture found that close to 24 million people lack access to a supermarket within a mile of their home. And a recent study found that low-income census tracts had half as many supermarkets as wealthy tracts. Another study shows that 8% of African Americans live in a tract with a supermarket compared to 31% of whites. Next, we see that low-income communities often lack healthy, high-quality foods in their nearby stores. So even in cases where produce is available, it's often lower in quality when compared to more affluent communities. As an example, a study in Albany, New York, points out that 80% of non-white residents were unable to find low-fat milk or high-fiber bread in their neighborhoods. I'll also mention transportation as being an important issue in terms of access to healthy food. This is especially true in rural areas that lack transportation options and generally have particularly long distances to stores. For example, in Mississippi, a state that has a particularly high obesity rate, over 70% of food stamp eligible households travel more than 30 miles to reach a supermarket. Then in many of these same areas that lack access to healthy food, we also see a disproportionately high density of stores like convenience stores, corner stores, liquor stores, etc. And nationally, we see that low-income zip codes have 30% more convenience stores, which often lack some of the healthy items that we see in larger grocery stores when compared to middle-income zip codes. We also know from research in tobacco that youth are frequently visiting convenience stores. Estimates show nearly half of all adolescents are visiting a convenience store at least once a week, which is pointing out to how many youth are routinely exposed to product displays and advertising for the many unhealthy products, as well as the fact that they're spending a lot of time in these areas with unhealthy food available. A 2017 study found that communities with a high density of outlets selling high-calorie processed foods, places like fast food restaurants and convenience stores, compared with ones that sell healthy food, that has a stronger association with obesity than communities that only lack supermarkets. So that's again pointing to one of those issues with the food desert measure that is only looking at access to grocery stores. This study is saying that the abundance of high-calorie processed food is having a larger influence. Unfortunately, we see similar disparities in the density of fast food retailers as we do with convenience stores. As an example, a study in New Orleans found that predominantly Black neighborhoods have 2.4 fast food restaurants per square mile compared to 1.5 restaurants in the predominantly white neighborhoods. If anyone's interested in exploring access in terms of some of the measures I've been talking about, things like grocery store availability or the density of fast food restaurants, the USDA's Food Environment Atlas is an interesting tool to use for that. It gives a spatial overview of community food access and statistics on a lot of these food environment indicators. So I'll make sure we share that tool in the follow-up notes. Again, it's probably no surprise to hear that the price of healthy food tends to be higher than the price of unhealthy food. In fact, some of our research estimates healthy food can be nearly twice as expensive as the price of unhealthy food per serving. But even beyond the fact that healthy food is generally more expensive, we also see prices being even higher in neighborhoods with high concentrations of Black and Hispanic families or in low-income neighborhoods. So, for example, not only do we see from this national study of large chain supermarkets that the price of soda is on average 62% lower than the price of milk, but we also see that the neighborhoods with a higher concentration of Black and Hispanic individuals tended to have an even lower soda price and an even higher milk price. In another research study that explores pricing in tribal communities, they found that these communities over the course of the 12-month study period were paying an average of $8.41 more for a basket of food items when compared to the national average. The last piece I'll touch on is more related to the built environment, which, remember, is thinking about the physical parts of where we live and work, our homes, buildings, streets, and infrastructure, and is influencing a person's level of physical activity. This is where ideas like neighborhood walkability, access to parks or green space, and safety would come into play. There's growing evidence suggesting that components of walkability, things like the quality of sidewalks, crosswalks, and just overall neighborhood aesthetics can impact residents' physical activity. And so as demand continues to grow for walkability and access to green spaces, unfortunately, lower income and disadvantaged groups are being systematically excluded from these neighborhoods. Evidence also suggests that perceived safety or actual crime rates can have a big impact on physical activity behaviors. And then as a final note, I'll mention here is the additional obstacles and exasperation of some of the existing barriers we already had to healthy eating and physical activity, things like, as a result of the pandemic, things like gym closures, reduced food purchasing power because of income loss, and the interruption of school meal programs across the country. Feeding America is a national nonprofit with food banks across the country. They estimate that 54 million more Americans, including 18 million children, may experience food insecurity because of the pandemic. And this is evident by the large spikes in demand by food banks across the country, which you'll see in the photo on the slide, and we've all probably seen in different news stories, the rise in use of food banks and food distribution, as well as the rise in supplemental nutrition assistance program enrollment during the pandemic. So that was just a quick introduction to the many ways environmental factors influence obesity. So now I'm going to transition into overviewing some of the strategies that are currently being used to address these factors. I think we have general agreement in the literature about the fact that lack of access to healthy foods is important and increasing evidence about all of the different consequences. But I think we have a little bit of a less clear picture in terms of the answers to what is the most effective solution, but I'll still present some of those solutions and ideas around solutions today. So I'm going to start by using this policy framework created by the World Cancer Research Fund International that uses evidence-informed policies to promote healthier eating. Their framework is called Nourishing, and it's based on 3 different domains: food environment, food system, and behavior change communication. And then they have 10 specific policy actions representing each letter. We can look at a couple of the specific policy actions that are particularly relevant to some of the things I've pointed out today. We can start by looking at using economic tools to address food affordability and purchase incentives. Research shows us that price is one of the leading indicators of purchasing behavior. So targeted subsidies have been shown to help overcome affordability barriers to healthy food for people on lower incomes. Incentives like financial rewards or price discounts have also been shown to encourage people to switch to healthier options. There's also emerging evidence from implemented taxes indicating that there's potential for effectiveness to reduce consumption. So this category is where taxes on sugar-sweetened beverages, which we have several examples of in the United States. There's places like San Francisco and Philadelphia that have implemented some form of sugar-sweetened beverage tax. And there's also many more examples internationally. Specifically, if we're looking at an evaluation of the tax enacted in Mexico, 1 peso per liter on sugar-sweetened beverages back in 2014. That evaluation found that there was a 7.6% reduction in the purchase of those taxed beverages and a 2.1% increase in the purchase of the untaxed drinks in the 2 years following the effectiveness of this tax. This category would also include targeted subsidies for the purchase of healthy food, things like what we see at some farmers markets where low-income shoppers are offered incentive funds to buy produce. Sometimes that's called double up bucks or different farmers market matching programs. This is also where we could probably include programs like SNAP or WIC in this category, as well as GusNIP, which is a program that was created by the Farm Bill in 2018 to fund projects that encourage SNAP recipients to purchase more fruits and vegetables. Recipients of the Gus Schumer Nutrition Incentive Program, GusNIP, recipients of those grants in 2019 included quite a few organizations that offered fruit and vegetable prescription programs, which is another option for addressing food affordability. I also talked quite a bit about marketing, especially targeted marketing, which is relating to R in the Nourishing Framework, restricting food advertising and other forms of commercial promotion. This is certainly a harder area to regulate in the United States with freedom of speech concerns. One tactic I'll mention that we can borrow from tobacco prevention is the idea of content neutral advertising laws. So that means that we're putting a restriction on the percentage of storefront that can be covered with any type of advertising, not just a specific type of advertising. So in addition to these policies being able to limit the advertising for unhealthy food, they're also able to limit advertising for other products like tobacco or alcohol. And there's often a strong rationale for these types of policies in terms of the ability for them to improve public safety and improve, beautify neighborhoods. An important note here on content neutral advertising restrictions is that in order for these restrictions to promote health equity, it's really important that the restrictions are enacted city or county-wide, applied in all neighborhoods, or applied in low income and communities of color where there is already the most advertising. When we see content neutral advertising ordinances applied only in higher income or white neighborhoods, often again for that purpose of beautification, this can end up exacerbating some of our existing disparities and creating an even more stark difference between neighborhoods. One more policy option to specifically protect children from targeted marketing would be to disallow tax deductions for the marketing of unhealthy food and beverages to children. So this is something that's recommended by both the American Academy of Pediatrics and the American Heart Association as a strategy for protecting youth. And then lastly, on the Nourishing Framework, I'll point out S, setting incentives and rules to create healthy retail and food service environments. One thing we see in this category is initiatives often led by public health departments, things like Shop Healthy NYC, for example, that pair nutrition education in communities with incentives for retailers to stock healthier options. So offering things like equipment, whether that's fridges or baskets, signage, or other promotional efforts to retailers that agree to promote healthier food or stock healthy food when they didn't previously. I'll also point out the Healthy Food Financing Initiative as an example of incentivizing healthy retail that we see in the United States. This was funding that was approved by Congress and distributed in grants to states to provide financial or other types of assistance to attract healthier retail outlets to underserved areas. Since its creation in 2014, Healthy Food Financing Initiative has supported nearly 1,000 grocery and other healthy food retail projects in more than 35 states across the country. Another source of policy options tailored more specifically to the United States comes from Trust for America's Health State of Obesity report, which is released annually and offers policy recommendations for federal, state, and local governments. I'll point out that they use two guiding principles in all of their policy recommendations. One of those being that policies should apply a multisector, multidisciplinary approach, since we know that a single effort in just one sector or discipline is probably not going to have a significant impact. We need collaborations that involve, for example, health departments, schools, transportation departments, local businesses, all sorts of agencies in order to achieve the results we want to see. And then the other guiding principle is ensuring an intentional focus on those populations with a disproportionate burden of obesity first. In their 2020 report, Trust for America's Health offers recommendations for federal, state, and local governments in the 5 main areas that you'll see on the screen. Increasing health equity by strategically focusing on efforts that reduce obesity-related disparities, decreasing food insecurity while improving the nutritional quality of available foods, changing the marketing and pricing strategies that lead to health disparities, making physical activity in the built environment safer and more accessible for all, and then working with the healthcare system to close disparities and gaps in clinic to community settings. The 2020 report also highlights the impact of the pandemic and points to how the pandemic has only intensified some of the longstanding structural and historic inequalities that we really need to address in order to make a true impact on obesity. There's a lot of overlap in these policy recommendations with some of the ones that I just covered in the Nourishing Framework, but I'll point out a few things from these recommendations that are more specific to the United States. Specifically thinking at the federal government level, these recommendations include things like expanding funding for CDC obesity prevention programs and increasing access and benefit value while decreasing some of the barriers to participation in our federal nutrition programs like WIC and SNAP. And then lastly, I want to look a little bit closer at the recommendations around physical activity and built environment, since I didn't touch on that with the Nourishing Framework. One option we have as it relates to physical activity is to advocate for increased funding for active transportation projects, things like sidewalks, trails, bike lanes, while making sure to do this equitably across all communities. Another option is to increase funding, again, to Safe Routes to School initiatives, which comes from federal funding designated specifically to improve infrastructure to promote walking and biking to school. There's also the option to push for changes in zoning laws, since that can play a role when mixed use neighborhoods tend to be associated with more physical activity. And then lastly, I'll mention complete street policies, which require that planning, design, and construction of roadway and transit facilities include the needs of all transportation users of all ages and abilities. So thinking about pedestrians, people using bikes, transit users, motorists, everyone when designing streets. To get an idea of how well your state is doing with some of these built environment policies, the map on the screen is based on scores from Safe Route Partnership's 2020 state report cards, which provides a snapshot of how supportive each state is of walking, bicycling, and physical activity for children and adults. So their report card goes into detail on how well each of these states is doing if you are interested in exploring more about your state. So to close, I'll point out some recommendations developed by the American Society of Clinical Oncology that can be used as suggestions for how those of you who work in cancer prevention and control can get involved. In 2016, the American Society of Clinical Oncology saw that there was a need for addressing obesity in their work, and they identified priorities for multidisciplinary collaboration focused on obesity prevention and treatment. The list on the screen is based on those priorities, specifically out of their policy and advocacy focus. So a first step, seeking to understand the relationship between cancer, obesity, and geography in your community, being able to use this data to better inform your resource allocation and assist in your advocacy efforts could be helpful. Another option, supporting increased funding for obesity research at the national level. We know there's a lot for us to learn, a lot that still exists for us to learn about the most effective strategies in terms of reducing the burden of obesity. Next, thinking about supporting the efforts of existing obesity coalitions. There's lots of opportunities to partner for advocacy efforts or other community level initiatives. So seeking out those partnerships can be a great first step. And then lastly, leveraging the collective voices of your networks to advocate for large systemic changes to the known environmental contributors to obesity. So being able to come together with a unified voice to advocate to policymakers that they focus on the environmental factors that we talked about today can be a huge help to folks working in obesity control and ultimately help with reducing the cancer burden in our country. So with that, I will answer some questions if we have any. I also want to, yes, we'll certainly make sure these slides are available. I want to mention to those of you on the call, another project that I work on with GIA, our Geographic Surveillance Learning Collaborative. In this project, we're working with cancer control and comp cancer teams to think through geographic surveillance in their states, specifically policy surveillance this year. So our second collaborative is already in progress this year, but if that's something, if policy surveillance sounds interesting to you, that's something you'd like to be involved in the future, we hope to offer this again. So feel free to reach out to GIA and we can make sure to get you all involved in the future. So that is all I have. And we can see if there's any questions.
Thank you so much, Elizabeth, for that wonderful presentation. So yes, as Elizabeth mentioned, now is our Q&A session or section, excuse me. If you have any questions, please submit them through the Q&A. We have a few minutes for that. So we'll give people a few minutes if they'd like to submit anything. And so it doesn't seem like anyone has any question right now, but as I think Elizabeth had her email on the slide. Oh, I just got a question. It says, our community funds programs that help prevent heart disease, but cancer is not one of the target priorities. And I think the question may have been cut off. So Amy, if you'd like to finish the question. Oh, there we go. My question is, can you help us present information we can use for grants?
So I'm not sure what sort of information you're looking for specifically. I guess thinking about how to think of cancer being a priority along with the other priorities in your funding. You're certainly welcome. I'll share some resources. Along with the slides, I'll share some of the resources I talked about today, and I think those might be helpful sources of information to talk about the burden of obesity and how that's related to cancer and how that's related to our environment. Luckily, a lot of funders are starting to see this relationship more clearly and including that in their funding requirements, addressing environmental factors to health as part of their requirements. So I'm hopeful that becomes an aspect of your grant that you can continue to address. Let me know if there's a more specific way I can help to answer that question. Or feel free to email me if there's specific information that you're looking for.
And Elizabeth, if you wouldn't mind in the chat writing your email again for anyone.
Sure.
Thank you. And there's another question that came in. Your suggestions seem to be a 30,000 foot view of the issue of cancer. Do you have any suggestions on how to more specifically address these issues in an effort to reduce cancer?
Yeah, that's a really good question. I know that this was really a big picture view of options that feel like they're very far from relating to cancer specifically. I can keep thinking through suggestions on more specifically addressing these issues. There's plenty of options in terms of thinking about healthcare and how that can address how cancer healthcare providers can specifically change some of their practices in terms of addressing obesity, since that's less related to place and less related to environmental factors. I didn't focus on that as much today, but that certainly exists. And I can certainly think about some additional suggestions there and try to provide some of that in follow-up. But yes, certainly touched on very big picture issues today and long-term goals, I think, for cancer prevention folks.
Great, thank you so much, Elizabeth. We have another question. Has Counter Tools adopted the food apartheid language?
We don't have an official stance in terms of language we use around food, so this is not something that's an official part of our stance, but we do, as you saw in our diversity and in terms of our diversity and inclusion stance, I think that the reasoning behind the food apartheid language fits with our overall stance and is something that personally I'm interested in considering or in using in my work.
And I don't think there's any more questions. So if it's okay with you, Elizabeth, we can conclude the webinar.
Yeah, that sounds great.
Yeah, so thank you so much, Elizabeth. The presentation was wonderful. And thank you so much to the webinar participants for your comments and questions. We really appreciate your participation. And as I mentioned earlier, the post-webinar email that will be sent will include the brief evaluation survey. If you wouldn't mind just completing that, it'll include a link for the webinar and slides and any additional resources Elizabeth would like to share. Elizabeth, is there anything you'd like to say before we sign off?
I don't think so. Thank you so much for having me. And feel free to reach out if there are more questions I can answer.
Great. Thank you, everyone, and have a wonderful rest of your day. Thanks for joining.
Thanks.